think people are still joining, but I think we'll make a start because it's 10 o'clock now. So I'd like to say good morning to everybody. And on behalf of HQIP and the entire Clinical Audit Awareness Week team, I'm absolutely delighted to welcome you to this really special celebration. And thank you all for joining us this morning in recognising and championing the outstanding work taking place across clinical audit. First and foremost, I'd like to extend a really heartfelt thank you to all of the organisers behind this week's event. The time, energy and attention to detail that goes into making this such a success does not go unnoticed, and you've done a truly fantastic job. Big thank you to all of our presenters this week. The range of topics you've brought to the table this week have been both insightful and inspiring. It's always a privilege to hear about the innovation and commitment that you're all doing to drive improvements in care quality, and you've certainly given us all a lot to think about and take away. To all of our attendees, thank you for being here, for all of your enthusiasm, for the passion you bring to the clinical audit and quality improvement community. Your engagement is what makes Clinical Audit Awareness Week such a meaningful event in our calendar, not just here at HQIP, but across the entire healthcare community. And finally, of course, a huge congratulations to all of today's award winners and runners-up. The field this year, I have to say, was incredibly strong, and the judging panel had an extremely difficult task in selecting just a few winners from such an impressive array of entries. You should all be incredibly proud of the work that you've done and the impact it's had. Clinical Audit Awareness Week is an important moment for us all to reflect, to share and to celebrate the vital role clinical audit plays in improving patient care. And today is about how we utilise clinical audit to achieve impact. Firstly, how we use data and evidence that we've derived from our National Clinical Audit, especially the National Clinical Audit and Patient Outcomes Programme, which is commissioned by HQIP on behalf of NHS and the devolved nations, which aim to improve care and outcomes for patients. And secondly, how we share exemplar practice to help others to do the same. As such, we will be announcing and hearing from the winners of the Using NCAPOP Data and Communicating for Impact Awards today. There's going to be a brief question and answer session at the end, which will be managed by the question and answer function and not via the chat. So please use that to add any questions for our presenters, and I'll read them out to the panel when the Q&A begins. So get your thinking caps on if there's anything you wish to ask our presenters. Before we move on to the main event, I've been asked to cover a few small amounts of housekeeping. This event will be recorded, and slides and recording will be available online within a few days. All of our microphones are auto-muted and will be kept muted throughout the presentations. Please can we ask that you leave your cameras on? We are, after all, a community, but do feel free to switch these off if you would prefer to do so. The chat function is available if needed, but mostly for technical issues and sharing links. And we ask you to keep the use of this to a minimum so we can concentrate on the questions and answers. Please feel free to share this event on social media using the hashtag CAAW25, and please tag HQIP in anything that you pop on social media. So without further ado, I'm now going to hand over to HQIP's CEO, Chris Gush, who will make the award announcements. Over to you, Chris.
Thanks, Rachel. I always feel at this point we should be on stage with a big gold envelope doing the awards, but lacking that, I will press on. The digital age does thrive here. So I'd like to present the first award. The first award is the NCAPOP Commendation. So this award celebrates projects that use the National Clinical Audit and Patient Outcomes Programme, or NCAPOP, data to drive healthcare improvements. We'll start with the runner-up. So the runner-up is Transforming End-of-Life Care Team from the University College London Hospital. The End-of-Life Care Quality Improvement Project was the winner, and this runner-up project showed how thoughtful use of NACL audit data can transform care at the end of life. Through strong multidisciplinary and multi-sector approach, they embedded equality, inclusion and collaboration at every stage. Their innovative use of data to support performance and evaluation and improvement demonstrates the power of audit to influence both practice and experience, showing great potential for wider impact. So congratulations. Moving on to the winner. So the winner is Dr. Emmanuel Okoro, Dr. Mamoon Rahman, Dr. Ikena Agbo, Bernard McMadey, and Tapan Kumar Brambut from the Morris Ward of Goodmayes Hospital in North East London Foundation Trust, and their project was Improving Physical Healthcare Audit. This winning project is an outstanding example of how local teams can harness national audit data to make a real difference. By taking a holistic, system-wide approach, they addressed health inequalities through preventative, multidisciplinary interventions. Their use of data informed everything from audit design to service improvements, resulting in tangible change like new staff appointments and integrated clinics. An excellent example of how local teams have used national data to look across the system to address health inequalities and intersectionality. So congratulations, and over to Dr. Emmanuel Okaro and Dr. Ikenna Agbo to present their project.
Thank you very much, Chris, and good morning, everyone. Thank you for the opportunity to share our work. My name is Emmanuel Okoro. I'm a consultant forensic psychiatrist, as has been introduced. And shall we just move to the next slide so I could get on with this? We know this is an established fact that people with severe mental illness, have significant health inequalities across the board. And the disparities in terms of access, experience, and outcomes, it's something that has been a challenge for a number of years. People with severe mental illness, such as schizophrenia, bipolar affective disorder, or other psychosis, actually have reduced life expectancy of up to 20 years from preventable physical health conditions, such as smoking and other preventable conditions that clearly we could do something about. They are more likely to present at urgent care centers and emergency departments. They are less likely to have annual health checks and the likes. And some of the factors that play a role in driving up the risk among this population includes the very core symptoms of the illness, lack of motivation, self-neglect, and the side effects from psychotropic medications, which could slow you right down and leave you wanting to do nothing, really. And sometimes there are poorly managed conditions such as diabetes or hypertension. Next slide, please. So just about the unit itself, this is a forensic low secure rehabilitation unit. And we host adults, male adults, usually 18 to 24 months or more. And we feel this provides a good opportunity to bridge that gap, the parity gap in terms of physical health care for people with mental illness. We are part of the North London Forensic Collaborative, and we are part of the Quality Network, and rated as good by the CQC, etc. We've been recognized for holistic MDT care within our setting. However, we've had challenges. Access to GP appointments could take several weeks. So you find some of the patients who stick around for 12 months, 24 months, don't have any annual health checks. And national screening as well was a challenge for some people who were eligible for bowel cancer screening, for example, or other conditions that required close monitoring. So we felt the need to do something about this. We put forward a business case, which was approved by the collaborative. And as part of that process, we carried out this baseline audit, which Ikenna will briefly summarize here, and I'll come back later on. So I'll just turn it over to Ikenna now. Next slide, please. Thank you.
Good morning, everyone. Thank you for the opportunity to talk about our work on Morris Ward. So our project aim was to assess physical healthcare offers and access against NICE guidelines for people with serious mental illness. So what we did was we reviewed the NICE recommendations for physical healthcare in these individuals and identify relevant standards like BMIs, cardiovascular risk assessments, and others as listed on the slides. So we collected data from the point of admission up until the point of the audits from patient's electronic record and benchmark this data against the NICE standards that we identified. We use this to identify gaps in physical healthcare access, experience, and outcomes, and make recommendations for improvement using quality improvement and other structured methodology. Next slide, please. So this slide just highlights the standards we audited against, our targets and our results. So the standards we used were body mass index, cardiovascular risk assessment, smoking cessation, substance misuse, and national screening. So one interesting thing we identified about our results was that we met all these standards at 100% in terms of offer and access. But the striking thing that this didn't necessarily translate to the desired outcomes that we wanted. Like for example, we had regular weekly weight monitoring, fortnight BMI monitoring, but we still had a significant proportion of our patients who were overweight and obese. We also offered smoking cessation interventions, both individual sessions, group sessions, nicotine replacement therapies. But what we noticed was from the point of admission up onto the point we audited, which some people had already stayed 18 months, 1 year, we didn't have anyone that quit smoking at that point. With our national screening, we offered eligible screening to all patients, but sometimes some patients are not willing to travel out of the unit for these screenings. And sometimes they just can't travel because of their mental state at the point. So based on these results, we felt like the need to make recommendations and improve our fiscal healthcare service in terms of uptake. Next slide, please. So these are recommendations based on the results we had. We employed an activity coordinator to extend fiscal activities into the weekend, and also co-produce individual activity plans for these patients so to meet their own individual needs. We also established a medical post with focus on fiscal health. This is to improve early detection of fiscal health issues, to liaise with GPs when we can't get appointments, and specialist services too. Sometimes we get guidance from these specialist services and GP on management of these patients on the ward when we can't get appointments. And sometimes so we have to just facilitate appointments to make them happen faster than they usually do. We've started aligning our BMI monitoring with individual care plans. For national screening, we've come up with, through collaboration with GPs and NHSE, we've come up with a system where bowel cancer screening sample can come.
It appears Dr. Ikenna has frozen. Okay, so the bowel cancer screening was done in collaboration with the National Screening Hub within our region. So we currently receive kits from the service for those who are eligible for bowel cancer screening, which is something we didn't have for several years. So if anybody is within the age bracket, you can be sure they would not miss the screening because they're in hospital, for example. And we intend to also pursue this further and follow them up right beyond their time with us to where they are placed in the community when they finish their care on the ward. And there's a tobacco cessation lead who's been appointed specifically for this purpose across the trust. We have awareness sessions, we'll have educational programs right now. The visibility of the lead within our community meetings has led to some improvement in terms of people wanting to stop smoking or to cut down on smoking. Ikenna, are you back now? Do you want to add anything to?
Can you hear me now?
Yeah, go on.
Okay, you basically said it all. The plan going forward is to re-audit in August, and after that, we've already had early indications of improvements in fiscal health, but by then we'd have concrete evidence, and hopefully we can share that too when that is done. Next slide. I would hand over back to Dr. Okoro to conclude the presentation.
Thank you very much. We felt it will be helpful to give you a bit of a visual sense of what's available within the unit at the moment. So we'll have a range of activities available to patients, some of whom are restricted by the Ministry of Justice and so can't have leave for several weeks and months. But if you look closely, we do have a range of activities in-house and in the community. So there's no excuse for anybody not to move, basically. We've got working groups who have an in-house gym now. So the activity coordinator can extend that to the weekends and people can have regular sessions. We also have a pets garden where we have guinea pigs and chicken, you know, and people can at least move and collect the eggs, if nothing else. So there is a lot of incentive there by using vouchers, for example, to get people to clean up the tables in the dining area, you know, collect the eggs, look after the chicken and all that, and receive vouchers for doing that. So this range of activities essentially champions the need to get people moving, however small people are able to do. Next slide, please. So the early indications are there for the patients on the ward, for staff, and for the trusts. As Dr. Ikenna mentioned, we have a few of the patients currently whose BMI have normalized. I think at the moment, we have about 6 out of 12 patients within the normal BMI range. And we've got just 2 people who are, you could say, in the category of being obese currently, and we're still working at it going forward. And we have just 3 people who've stopped smoking or who are non-smokers currently out of the 12. We're hoping to have that number increase with time. There's clearer sense of guidance and nice guidance in terms of care planning around physical health care on the ward currently, and also improved specialist service access at the moment. The trust feels proud that will be nominated, and this award will go to strengthen our adherence to NICE guidelines and also our commitment to quality improvement. So we will re-audit in August, and hopefully we should be able to share some of the data from that and to use QI to continue to drive change. I think we'll have one more slide to conclude. So the key takeaway message here then is, if we are involved with anybody at all with mental health problems, especially severe mental illness, smoking cessation and physical health, physical activity are 2 key factors that could drive down the risks associated with physical health, poorer outcomes for us. And I think we can make a difference if we can get people moving. And you'll probably be aware that smoking is linked to the 5 key areas in the core 20+5 NHS, healthcare approach to driving down inequalities. If people stop smoking, their outcomes will pick up right away. If they can move at least 30 minutes on a daily basis, that improves the prognosis for quite a number of our patients. I think that's the end of the presentation. Thank you very much. We'll be happy to take questions later on.
Thank you very much. It's fascinating, and it's really great to see the national audit programs also influencing kind of that local change. So it's brilliant to see. Thank you very much. So I'm going to move on now to the communicating for impact commendation. So starting with the runner-up. The runner-up is Anna Skipper, the Falls Prevention and Management Lead from Norfolk and Norwich University Hospitals NHS Foundation Trust. Congratulations. And the project is Falls Prevention Improvement Project. And in this project, Anna used authentic storytelling and targeted messaging to deliver powerful communication. Her work with national partners brought the project to life, while dissemination through NHS Futures platform and National Summit showed real reach. With compelling video at its heart, the project proved how content-led communication can engage audiences and leave a lasting impression. I'm now going to move on to the first joint winner. The first joint winner is Isabel Diaz-Martin, Peter Brooks, John Paul, and the Paediatric Recovery Team at the Chelsea and Westminster Hospital. The project was implementation of the Cornell assessment for paediatric delirium as a vital sign in the paediatric post-anaesthetic care unit. This winning project demonstrated a creative, strategic approach to communication, sharing the impact of their work through multiple channels. Highlights include a Dragon's Den style event and a national level recognition, which helped amplify their message and inspire wider engagement. By combining innovation with clarity, they showed how communications can be a powerful driver of influence and improvement. I'm now going to hand over to Isabel to present their project.
Good morning, everybody. We're incredibly honored to receive the Communication for Impact Commendation Award for our project focused on the implementation of the Cornell assessment for pediatric delirium in the post-anesthetic care unit. that aims to improve recognition, management, and future prevention of emergency delirium in our pediatric patients. I'm Isabel Diaz-Martin, PACU, or recovery nurse. With me, Dr. Brooke and John Paul. Dr. Peter Brooke is being our sponsor, is one of our consultant anesthetists, and John Paul is a medical student that was with us for around 5-6 months helping on the project, and of course our recovery team essential for this. On the next few minutes, I'm going to talk about our quality improvement project and how communication supported change, following steps for communication like setting goals, identifying our priorities, audience, messages, channels. So a bit of background for some of you that might not be familiar with what is a PACU, what is pediatric emergency delirium. So a bit of background. So emergency delirium affects 10 to 30% of our children recovering from anesthesia. It can be distressing, dangerous, and frequently is underdiagnosed, and is frequently not screened at all. It has a big impact on our patients, on our families, in our hospital resources, in our theater productivity. In March 2024, we conducted our first audit in our post-anesthetic care unit, and we found out clear gaps on emergency delirium recognition, on documentation, and we wonder how can we prevent something that is not documented, and also in our staff confidence. And there was no standardized screening tool integrated into our EMR. This was our call for action, and our purpose became clear: make emergency delirium visible, measurable, better managed, and work towards improving prevention. And next slide, please. So we asked ourselves, who do we need to reach? What do we need to communicate? What purpose? And we selected the CAPD tool for screening, but the tool is not useful if it's not integrated well. So we built a strategy around using quality improvement methods. So we identified knowledge and gaps, trained staff on ED recognition and CAPD application. We integrated the CAPD into our clinical workflow. We had to design a clinical workflow for the use of the CAPD as well. This is what you see a little bit on the right down side there. That's a clinical workflow. And that had to be already approved by our pediatric stakeholders across Northwest London Children's Hospitals. So that was a great opportunity to share what we were doing. And we did study. We assessed staff confidence on ED and our documentation rates. And then we are working towards the full integration into our EMR. And next slide, please. So we didn't just communicate, we measure impact. So we have, as a result, we do understand now that universal screening and documentation for pediatric ED integrated into our workflows. We have that. We built an infrastructure to collect clean and various fit-for-purpose data for further research and innovation. We enable medical staff to identify patients that had emergency delirium before, and they are coming back to have surgery again. So if they had it before, now they can have a different approach from non-pharmacological to pharmacological interventions. So these children, we already prevented emergency delirium from happening again. And that's only happening now on the last year because it was highly documented before. And we are here to improve patient safety and staff confidence and work more efficiently. And we are contributing for a better surgery pathway. On the graph, you can see, if you see the red and orange lines, you can see we did several audits. And this red and orange is when we were screening for emergency delirium only when the nurses were thinking that was happening. And then with the recommendation change when we approached one of the professors from the Cornell Institute and Research at New York, Professor Konitrov, she recommended to do a screening in all our patients, and that massively changed because we were missing all the hypoactive delirium. We will never suspect of a child waking up on hypoactive delirium if we will not screen all our patients. Next slide, please. Oh, it's a little bit different, the slide I sent you. I'm so sorry. Yeah. So what did we learn? I'm so sorry, you cannot see all I've written there, but I will focus on two of the main things we have learned from this is that a tool needs training and culture. That did work because it was owned by the team. And sustainability depends on education. Change sticks when we invest in our staff development. We now see emergency delirium as a quality indicator and CAPD as a shared language. We keep learning and refining our processes. This has not finished just yet. Next slide, please. So this project only succeeded because we engaged the entire recovery team, our nurses, also our anesthetists, our sponsor anesthetists. It was a very big, very big important factor, and also our stakeholders that we were able to engage them from the very beginning. And this work went beyond our hospital. So we had the opportunity to already present it last April at the Barna Conference, National Conference for British Anesthetic and Recovery Nurses. We had the opportunity to present it on the NIHR Nursing and Midwifery International Day, where I had the opportunity to work on the Dragon's Den activity, and that has reached the research network. And also on an international conference, the APAC-B, where it's the Association of Pediatric Anesthetists of Great Britain and Ireland, and there was also a representation, big representation from the States. And just the last slide, please. So I just wanted to say that communication can transform clinical practice and patients' outcomes. Through our project on pediatric emergency delirium, we demonstrated that communication is just not a tool for change, it's the change. By embedding the Cornell assessment of pediatric delirium CAPD screening tool into our PACU workflows, empowering staff through education, and using communication channels, we built shared understanding, we achieve safer care, improve documentation, and stronger team confidence. We believe this initiative is scalable, sustainable, and valuable to other members of the other NHS organizations, and sharing our experience help promote best practice and reinforce the message that communication is a vital part of patient safety. This award offers the opportunity to inspire others to prioritize meaningful engagement, collaborative planning, and purposeful messaging in quality improvement efforts. Thank you very much.
Thank you as well. That was brilliant to see, and I think I really liked your last sentiment there about communication enabling the change and actually driving it forward, and congratulations there. I'd now like to move on to Communicating for Impact Commendation, the second joint winner. And the second joint winner is the NACEL team. So that's the team from the National Audit of care at the end of life. The project was led by Jessica Moss from the team, and this project impressed with its bold, long-term approach to communication, reaching beyond the usual audiences to influence national policy and share learning across borders. Their interactive platform created a space for sector-wide best practice sharing, and their engagement with the 10-year health plan showed a clear ambition to shape the future care through thoughtful, high-impact messaging. So I'm now going to hand over to Joylyn Brockett, who's presenting the project on behalf of the NACEL team.
Hi, morning everybody. Yes, I'm Joylyn Brockett. I'm a Senior Project Manager for NACEL at NHS Benchmarking Network. And as Chris said, I am filling in for my colleague Jessica Moss, the NACEL Quality Improvement Lead, who has led on lots of this work. So I really have to thank her for all of her hard work within this project. So yeah, on behalf of the team, we are delighted to be recognised as effectively communicating the audit impact and for being given the opportunity to share some of our work. Next slide, please. So a bit of a brief overview about NACEL. NACEL is a national comparative audit of the quality and outcomes of care experienced by the dying person and those important to them. And the audit focuses on care being delivered during that last admission to hospital before death. The audit looks at care being delivered in acute hospitals, community hospitals and mental health hospitals across England, Wales, Jersey and Northern Ireland. And at the network, we have delivered the audit for a number of years, starting in 2017, and we're currently undertaking our 6th round of data collection, and that will close at the end of the year. So the audit is commissioned by HQIP, and under our HQIP contracts covers the care being delivered in England, Wales and Jersey, and then the network also commissions, sorry, my camera keeps freezing, so I might just turn it off. The network also works with the Public Health Agency to deliver the audit in Northern Ireland. Thank you. Next slide, please. So how do we communicate? We have several routes of communicating with our stakeholders, and some of those are shown within that smart image in the centre of the slide. But our main audience that we communicate with are the healthcare professionals working within the acute hospitals, community hospitals and mental health inpatient facilities. But we've also included some examples of our other stakeholders on the right-hand side of the slide. And our communication methods have evolved over the years based on the skills that we have within our audit team, the different access and subscriptions that we've got to different tools, the capacity within our audit team, and also the feedback that we've got from our stakeholders and how they find our different comms. Next slide, please. So one of an example of how we communicate includes our NACEL newsletter. So we send out a monthly newsletter to over 700 health and social care professionals to inform them of the latest updates and news. We use MailChimp to send out the newsletter, as we found that it looks more professional, and a benefit is that we can then analyse how well people are engaging with it. So our stats from last month showed an open rate of 30% and a click rate of 8%. And all of the content that goes into our newsletter is then further shared on the palliative and end-of-life care workspace on NHS Futures. So just trying to reach a wider audience as well. Next slide, please. Another example of how we communicate is via our portal. So this is our dedicated audit website that has information about data collection and our outputs. The website's hosted on Squarespace, and we get an average of 4,000 visits a month. And there's just 3 specific pages that I wanted to mention that we have on the portal. One being our patient and carer voice page. And this is where we've been able to demonstrate some of the work that we've been doing with our patient and public involvement group, including a video that we have from a gentleman discussing his experience of care at the end of life. And it really just acts as like a powerful demonstration of the importance of improvement work and of the audit. Another another 2 pages, which we have actually recently published, is our Good Practice Compendium. And this is a dynamic page which showcases 68 examples of good practice in quality improvement work. And it's fantastic to see that UCLH have actually been commended for their improvement work today, as they also feature within our NACL Good Practice Compendium. So yeah, that's fantastic to see. And it says coming soon on the side, but we have actually recently published our Impact Compendium. And again, this is a dynamic page on our website that shares over 200 local examples of how hospital sites have used participation in NACL to improve, or it's had an impact on their local end-of-life care service models. Next slide, please. So these are just some of the examples included in our Impact Compendium. So we've got a broad range of examples, from using the data to support business cases, or using the data to support with staff training and education. And we've collected these examples by including a specific question within our data collection. And then the intention behind us then sharing that on our website is to demonstrate the value of participating in the audit, to encourage shared learning amongst trusts, and hopefully giving people some ideas on how they can best utilise the data for local quality improvement work, and to also encourage networking amongst trusts. Next slide, please. So we also communicate by delivering presentations. We run multiple events throughout the year. These are free to attend, and they include our drop-in sessions, our quality improvement huddles, and our quality improvement webinars. And within these presentations, we demonstrate how to use the audit outputs to support quality improvement, and often get good practice speakers to talk about their experience of using the audit. And then all attendees are then sent a certificate to include in their professional portfolio. Next slide, please. Great. And other examples include delivering professional presentations and publishing academic outputs. Our clinical team take every opportunity to present at external conferences. We've got an image here of them presenting at the Palliative Care Congress, which took place earlier this year. And we are writing evaluation pieces and trying to publish them within the British Medical Journal. So we are looking to publish another one later in the year. I think we've got 4 on the website so far. And we're also feeding into national programmes as much as possible. And we've recently provided data to support the Health and Social Care Committee's independent evaluation of palliative care in England. And that report is shown on the slide and also available online. Next slide, please. And then the final method of communication that I wanted to mention is via our community of practice. So this is a group that we've developed to support clinicians, commissioners and providers in quality improvement work using NACL data. And the aim is to provide support, shared knowledge and materials, and to collaborate more effectively. The group at the moment is very much in its infancy, and it's hosted on our NACL portal, but we are developing a new platform in collaboration with the Q community at the Health Foundation, and we're hoping that this innovative approach will then help further increase our reach and the impact of NACL. Next slide, please. Great, thanks. So to conclude, our communication of impact has been driven by several key enablers. I think one is the fact that we've been recording how the audit is being used locally via our data collection. It's meant that we've got lots of examples to share. We are analysing our engagement to adapt how and what we communicate in the future. We've been able to trial lots of different mediums of communicating, from academic journals to social media posts, and that has helped us reach wider audiences. And collaboration has remained central to everything that we've done, and that's really helped by having a really engaged and active steering and advisory group. But there have also been challenges that we're actively working on. So making sure that the right message reaches the right audience at the right time. There's a challenge of overusing emails and wanting to avoid email fatigue, especially in already busy inboxes. And then finding effective ways to engage frontline clinicians whose time is limited. So yeah, there's still lots we want to do as an audit provider, and as time goes on and we learn more, I'm sure our approach will evolve. But that concludes the presentation, so thank you.
Thanks, Joylyn. I think it's amazing to see, and also great to see how you're driving and highlighting how the audit's being used locally for local quality improvement purposes, all the way through to that kind of national policy influencing. And it really shows the power of what national audit programs can do and how they can influence. I'm now going to hand back to Rachel, who's going to have a Q&A session with all the winners.
Brilliant.
Rachel,
Thanks, Chris. Thank you. And I really echo Chris's thoughts and words there on those presentations. They're fantastic presentations, and I've really enjoyed listening to them all this morning. It's great work that you've all been undertaking. It really shines a light on clinical audit and the power of the data that we've all got now, and how that really does have such a positive impact on all of our healthcare service users. We know that you all work in very pressurised environments and times in the NHS and in the other sectors that you all work in. So all of this work should really be highly commended. I'm going to open up the Q&A now. I haven't got anything in the chat at the moment, Lacey, but very happy if anybody wants to pose the first question for any of our presenters today.
So I put something into the Q&A for you, Rachel. I can read out the first question. The first question from me, a starter for 10, is for Dr. Ikenna and Dr. Okoro. And I was just wondering how you came up with such innovative set of activities to get patients involved. I mean, honestly, from caring for hens through to football, it was amazing. Did you involve patients in coming up with those ideas?
Absolutely. So the projects running within the unit are all co-produced. We actually have a co-production group that's attended by patient reps and staff. So yeah, they were all co-produced, and we're hoping to pursue specific change ideas using the QI methodology in the coming months, which the patients are also helping us drive. So yes, in answer to your question, that's just the sort of the culture that we are trying to promote within the unit is to have co-design and co-production as the way to do things within the unit.
And do you have any final ideas up your sleeve that you're going to introduce in the future, or?
Yes, we are looking to introduce Fitbits, which is part of the drive towards summer. To hopefully get people moving and to be able to count steps, and there's a prize to be won for that. So the biggest loser in terms of weight loss with the Fitbits count will win a prize, and also smoking cessation. We are hoping we can acquire carbon monoxide sort of monitoring kits so we can check to see those who've actually stopped, reduction in the number of cigarettes people smoke or vapes people use. So such things, those are the ideas at the moment we're sort of mulling over. And we hope by summer we should have that up and running.
That's wonderful. Thank you. Rachel, are you happy to read out my next question, or would you like me to?
I'm happy if you want to read out your next question, Lacey. That's absolutely fine.
Okay, and my next question was for Isabel Diaz-Martin. I mean, first of all, apologies for the issue with one of your slides, but we're always interested in innovative ways to spread the word. I'm in comms myself. Can you tell us more about Dragon's Den?
Yeah, so one of our research nurses at the hospital that I've been in contact with recently, because one of our main things at the moment is collecting all that data that at the moment it's on a form of template, is in our electronic record, but it's on a form of template still. We are still working on the full integration into Cerner. So one of the things I've been in contact with her is because we needed some allocated time for somebody physically spending time to collect that data, because at the moment it's quite inefficient. At the moment, there is not much money at the hospital to finance that. So she mentioned about this Dragon's Den activity where, well, it was a price of £1,000 for research activities. And I know it wasn't a lot, but I thought this is a great opportunity to be there to talk about it, to get the research network. Well, let's see what happens. So I attended. I sent it was through a pitch. So I sent my application. They selected me and another two for pitch presentation, why I wanted this research £1,000 for a research. And there we go. I got it. It was a bit of it was only because our research team mentioned to us they were trying to find something for us to get some resources for us to work into getting this data collected. So it was a great opportunity, and now I'm working with them for a whole year with guidance, and we will deliver something next year on the next Dragon's Den activity. I will showcase what I've done.
Okay, that sounds great. Do share it with HQIP. We'd love to share news of that when you present it.
Definitely.
Rachel, back to you.
Yeah, lovely. I've got a couple of questions in the chat now as well. One from Jordan at South Tyneside and Sunderland NHS Trust, and posed a question perhaps aimed more at the teams from NHS trusts. How important was it to engage with other teams within your organisation? For example, teams such as communications, information services, patient experience, public health, etc. It's not always easy building these connections within an organisation. Interesting question to pose there for people working in trusts. If anyone would like to pop their hands up to answer. Any of our presenters got any thoughts on that?
I guess while people ponder that, we could move on to, there's a question in for Joylyn, and then we may be able to get people back to answer.
Yeah, absolutely. Oh, Emily, you've popped your hand up.
Yes, it was only to answer that question using our example at UCLH. I would say it's really about relationship building, and that really takes time. So visibility and trying to attend as many committees and other meetings and understand what's going on, build relationships, spend the time to do a bit of work on their agenda, and then they'll do a little bit of work on your agenda, and to make sure that the organizational structures, insofar as you're able to influence them, kind of enhance those relationships. So I think it's absolutely key to influencing change is really that relational work. And the difficulty is, especially as clinicians or whatever our roles are, that we don't have limited time. So it's about how can you get the maximum impact with the least time, but to get your face known in the right places. And for me, that has been absolutely key.
Lovely. Thank you very much, Emily. And actually, I think the next question is from you. So I'm very happy for you to carry on and take the floor. And
thank you.
Dr. Coro, did you have a response for Jordan's question?
Yes, Rachel, I just wanted to highlight, I think the collaboration across several trusts and services is key to learning, innovation, and and doing things that that would really make a difference. We're part of the North London Forensic Collaborative, which is made up of 5 different trusts cutting across North London. That has really helped us a great deal to sort of share learning from across the system, the NEL ICS, and also the funding that's come from that, and the sort of support has really been helpful in helping us push change. So I think communication, building relationships, as Emily has highlighted, is really key to making a difference. So I just wanted to support what Emily said.
Lovely. Thank you very much, Dr. Corey. Emily's question is for Joylin. How might cultural competence, a key focus of our care at UCLH, be further championed going forwards through the NACEL audit? That's one for you, Joylin.
Yeah, thank you. It's a good question, and I'm hoping that, well, you'll start to see more examples of work that we're doing coming forward. So on the 26th of June, we are hosting our next quality improvement webinar, and the focus of that webinar is how to use the NACEL data to support improvement around addressing spiritual, religious, cultural needs. We've got two good practice speakers coming, two good practice speakers from different trusts talking about the improvement work that they've been doing. And we've also got a keynote speaker from the College of Healthcare Chaplains also coming. So that's one way. And hopefully once our recommendations for the NACEL 2024 audit are published in August, you'll also see some recommendations around supporting cultural competence within our recommendations. But yeah, that will be published in August.
Thank you.
Lovely. Lacia.
So I was just going to follow on and ask Joylin my starter for 10 question, which is a bit more generic, but it is about communications after all. And I just wondered if you had any thoughts on how the recent increased profile of end-of-life care in the media and so on at the moment has affected your communications?
Yeah, it's been tricky, but it's also shone a light on palliative and end-of-life care. So it's meant that we've had more invitation to come and present at different conferences. I think it's meant that we've had to, whilst there is such a shining light on end-of-life care, make the most of it and try and publish as many papers and get our name out as possible. So I think we're trying to use it in a positive way and make sure that we make the most of this time. But yeah, we've been invited to more, and there's been more opportunities to collaborate with end-of-life care partners. Yeah,
I understand. It's a tricky balance to strike, but I think when you say make the most of it, we all understand that that's with sensitivity too. I guess we could ask a similar question of Dr. Okoro as well, which is, the increased profile of mental health, and wondering how that's affected your work.
Absolutely, and some of you would have seen the news. I believe it was Sky News that brought a spotlight on King George Hospital actually a couple of days ago about mental health patients in crisis lying on the floor at the A&E waiting for days for beds, etc. And I think that always will stir up conversations as to, what's going on, what can be done, etc. So I think the media and a political discourse would always have a way of sort of driving up these issues for conversations to be had. We can only hope to then leverage on that, those of us who provide care on the front line, to use that to push for change in our small locations or places where we find ourselves. So yes, absolutely, it has led to quite a few conversations in-house. We'll watch this space to see what happens with the government and the agenda.
And hopefully to see increased funding too follow.
Yeah, absolutely.
Yeah. And I have a sort of a follow-up question, sort of talking about funding, Dr. Corey. So obviously you're working in the mental health sector, and we know that's chronically underfunded and under-resourced. How much work are you able to do with community and sort of things that you could get in for free, sort of your community stakeholder buy-in? Are there people that give you the chickens? Are there people that donate things? And are you working with weight management services? So do you have people come in and do sort of weight management classes with people, as we would see in a sort of a normal environment?
Yeah. We have had some support and collaboration with, vocational social enterprise establishment in the locality. But I think we're really fortunate because the forensic services tend to be better resourced in some sense. So we receive funding from the collaborative, we receive networking across the piece. Such that we can do things like Hopping Through Football, because the charity that runs it is available to us. We've launched what we call a cafe, Sunflowers Court Cafe, within the unit, where people can go and work and actually serve there to get paid for it. And that's in collaboration with a charity called the Redemption Roasters. So there's been quite a broad range of networking and collaboration across the piece. But it's often very difficult to have people where a huge amount of money is involved, of funding, to get the support you need is always a bit of a drag, so, and would always be a challenge, especially given the current climate where the ICS is being cut down, NHS England and all that. So it's a very challenging time. And the issue of triple lock across several trusts now means that you cannot even get basic things done. So we're having to be quite creative and innovative in the way we push for change. I'm not sure if that's fully addressed the question, but you get the gist. It's a challenge currently, and I wouldn't want to be a bit more political about it. So, yeah.
No, that's a really helpful response. Thank you very much, and thank you everybody for taking the questions as well. I don't think we've got any more questions in the chat, and we are coming towards the end of our session now. So I've got a few things to remind you of. If Drew, if you could pop the next slide up. Fantastic. So I won't read from the whole slide, but just wanted to remind you that at 12:30 today is our final lunch and learn around efficiencies. You'd be all very welcome to that if you've registered. We've showcased a new patient safety case study, which is available on HQIP's website. It's the optimisation of resident doctor rotas in clinical critical care from Epsom and St Helier University Hospital. We've also shared the links here for the clinical award winners and our NCAPOP programme. So all the links there from our HQIP website. You can log on to all of these and have a little look at all of our services. As I said at the beginning, these sessions have been recorded and will be shared in a few days' time by email and on our website as well. So it's just really for me and Chris and all of the clinical audit awareness team here at HQIP to say thank you so much for all of the work that you do in your local communities and throughout all of our audits. It's been a fascinating session. I've been delighted to be part of it. And I thank you all very much and really hope you've enjoyed the week, because without you, it doesn't happen. So thank you very much.